My name is Nicholas Kuhl, and I'm a Vanderbilt medical student. Today, I'm going to tell you about the special considerations that healthcare professionals ought to take when caring for LGBTQ older adults in both the primary care setting and at the end of life. Before we begin, let's talk briefly about important LGBTQ concepts and terminology. In order to understand LGBTQ older adult populations and its health disparities, it is important to define the distinct yet core concepts of sexual orientation and gender identity. Sexual orientation is how a person characterizes their sexual and emotional attraction to others. Common terms include lesbian, gay, bisexual, queer, straight, pansexual, and asexual. Conversely, gender identity is a person's internal sense of being male, female, both, neither, or another gender altogether. Gender identity doesn't always correlate with how an individual expresses their gender, nor with the chromosomal makeup of their somatic cells. There are three important dimensions of sexual orientation: behavior, attraction, and identity. In two recent studies of American adults using data from the National Health and Nutrition Examination Survey, less than half of men and women who report sexual intercourse with members of the same sex identified as gay, lesbian, or bisexual. Thus, it's important to realize that variations in the applicability of this terminology exist from one patient to the next. Before talking about the specifics of caring for LGBTQ older adults, it is important to contextualize the next few slides within the growing attention that this population has garnered over the last decade. In general, there are three cornerstones of successful aging as defined by the Movement Advancement Project and SAGE, which is an advocacy and service group for LGBT older adults. The cornerstones include economic security, social connections, and general health and well-being. However, as this graphic demonstrates, LGBT older adults face a lifetime of disproportionate discrimination and lack of legal and social recognition, a reliance on one's chosen rather than biological family, and a lack of competent healthcare providers who are inclusive of this population. From an epidemiological standpoint, 4.1% of Americans in 2017 identify with the LGBT community, which accounts for nearly 9 million people in the United States. Of older adults, 2.4% of baby boomers and 1.4% of individuals over the age of 72 identify as lesbian, gay, bisexual, or transgender. This equates to 2.7 million LGBT adults greater than 50 years old, and, of this group, nearly 1.1 million over the age of 65. SAGE predicts that there will be 7 million LGBT Americans over the age of 50 by 2030. In reference to the application of correct terminology, it's important to note that these statistics refer specifically to the number of people who identify as gay, lesbian, bisexual, or transgender. It is thought that roughly twice as many people engage in same-sex sexual behaviors. From a public health standpoint, these are the highlights of only a few conditions. This slide does not encompass all of the health disparities faced by the LGBT community. With regard to HIV and AIDS, nearly half of all positive individuals are now over the age of 50. In addition, this group accounts for 17% of new HIV cases yearly and 24% of new AIDS cases, which predisposes them to an increased risk of opportunistic infections and transmission to others. Recent data has shown that older LGBT adults have a less robust immunologic response to antiretroviral therapy. Furthermore, while medication adherence is generally good, there may be increased risk of drug toxicity because of age-related pharmacokinetics changes. With respect to cancers, older gay and bisexual men are 43 times more likely to develop anal cancer and 88 times more likely if they're positive when compared with age-matched straight men. In addition, this group has higher rates of liver cancer secondary to chronic hepatitis infection, Kaposi sarcoma if HIV positive, and lung cancer due to higher smoking rates. Older lesbian and bisexual women have a higher incidence of breast and cervical malignancies since this population generally receives less preventive care, accesses healthcare services less frequently, and enters the healthcare system at a later time. In general, the LGBT population has higher rates of smoking tobacco products in comparison to cisgender, heterosexual males and females. Finally, Dean et al. 2000 showed that the prevalence of alcohol abuse is similar among homosexual and heterosexual men, while Song et al. 2007 reported a higher risk of alcohol abuse among homosexual women when compared to straight women. For many decades, LGBTQ individuals have been avoidant of the healthcare community, largely due to fears of discrimination. These fears have led to an avoidance of care, particularly at nursing homes and assisted living facilities, that underscores the non-disclosure of sexual orientation to healthcare providers. 40% of LGBT older adults between the ages of 60 and 75 say their healthcare providers do not know their sexual orientations. This non-disclosure has significant consequences, such as the provision of inappropriate preventative care and screening recommendations, as well as the perpetuation of a poor patient-provider relationship and the setting of a heightened sense of invisibility among patients. From a primary care standpoint, LGBTQ older adults receive less preventive care and enter the healthcare system later. Though attention should be given to entire review of systems and functional status, I've elected to emphasize a few special clinical considerations when caring for older LGBTQ patients. To begin, older adults are sexually active. 53% of individuals between the age of 65 and 74 years old and 26% between 75 and 85 years old engage in sexual behaviors. On top of this, these individuals are at an increased risk of HIV infection and other STIs, as 92% of older adults do not use condoms. In 1994, Stahl and Catania found that 48% of LGB adults do not use condoms regularly. With regard to mental health, a study from 2001 found that nearly 13% of this population reported suicide attempts in 2000 alone. It is unclear how or if this number has changed today. This suicidal ideation is thought to be linked to higher rates of loneliness, increased internalized homophobia that stems from aging in a generation that's less accepting, and non-disclosure of sexual orientation to healthcare providers. Finally, and arguably one of the most important take-home messages from this lecture, preventative care in the transgender community. It is integral for healthcare providers to realize that 12% of trans women, male to female, and 1% of trans men, female to male, transition after the age of 55. Take, for example, Caitlyn Jenner. The older transgender community has been shown to have greater morbidity when compared to age-matched counterparts. This could be related to significant medical problems that stem from taking black market hormones, as well as to an overall lack of appropriate preventative care. It is important to ascertain the nature of a patient's transition in order to determine appropriate screening measures, such as prostate cancer screening in a trans woman or cervical cancer screening in a trans man. This slide demonstrates differences in overall health outcomes, particularly with respect to functional status, between the LGB population and heterosexual older adults. Gay and bisexual men are more likely to have a disability, ADL and IADL limitations, and mental distress when compared to heterosexual men. Similarly, lesbian women are more likely to have overall poor general health and mental distress when compared to heterosexual women. Now, I'll briefly touch on special considerations when caring for LGBTQ patients at the end of their life. A study from 1992 found that many LGBTQ older adults have concerns about advanced care planning, including the creation of a living will, due to an uncertain support network that leads to lack of clarity about who should be named in the document. In addition, many older adults fear that they'll be discriminated against in long-term care facilities such as nursing homes or assisted living. When broaching the topic of advanced care planning, it's important to understand that many LGBTQ individuals may not be close with or identify with their biological family, that is, the family they were born into. Rather, a chosen family is a group of individuals who, though not biologically or legally related, are emotionally close and consider one another to be family. Lastly, with respect to advanced directives and respectful remembrances, it is imperative to allow individuals an opportunity to include their preferred names, pronouns, and forms of gender expression in the document. Identification of a surrogate decision maker and an advanced directive may also be difficult, as the patient's biological family members might not actually represent the wishes of the patient. With regard to long-term settings of care, it is important to note that in 2006, The greatest concern of the aging LGBTQ baby boomer population was discrimination. To circumvent these fears as the population continues to age, particularly with respect to placement in nursing home and assisted living facilities, this map shows the current and under construction LGBTQ welcoming senior housing facilities across the country. Despite the incredible opportunity these facilities give to their residents, the total number of beds is minuscule compared to the need in the community. This merely serves to underscore the importance of cultural competence training for all senior housing facilities in every community. Finally, let's talk briefly about pathways to success in the clinical environment. This particular slide provides examples of ways in which you, as a provider, can inquire about a patient's relationship status and sexual activity in an unassuming, non-judgmental manner. This slide is intended to be a resource for healthcare providers to access as a means of improving the clinical environment. And finally, in addition, here are some extremely helpful links for all members of the medical team. I'd like to close with a photograph of the late Eddie Windsor, who was an LGBT rights activist and lead plaintiff in the Supreme Court case that overturned the Defense of Marriage Act. If you have any questions stemming from this presentation, please direct them to the Program for LGBTI Health. Thanks for watching.